Okay, picture this. It's 3 a.m., you're on call, and the pager just goes nuclear. First page, a pre-op patient. Major case tomorrow, sodium's 128. Is it even safe to take them to the OR? Before you can even think, another one comes in from the neuro ICU. Subarachnoid hemorrhage. Sodium's now 121, and it's dropping. You get that sinking feeling in your stomach, right? But what if I told you there's a clear, confident plan for both? All right, let's break this down. The first thing, and I mean the most important thing, you have to get is that a low sodium number almost never means the body is actually low on salt. What it really means is the body is holding on to way too much water compared to its salt. So from right now, let's just reframe this whole problem. Sodium isn't a salt story, it's a water story. And you know what? To completely master that water story, all you need is this simple, super powerful framework. We're gonna burn this into your brain. Ready? Osmolality first, volume second, and rate of correction always. This is our roadmap for everything. So let's start by building the foundation. To really get the water story, we have to know where all that water actually lives inside the body. And trust me, it is not the same for every single patient. Getting this right is an absolute cornerstone of good surgical care. Now check this out. It's kind of fascinating how much total body water changes from person to person. A newborn? They're basically a little water balloon sitting at 80% water. Now compare that to our textbook 60% for a lean adult male. But here's the kicker. As we get older, or as body fat, which hates water, increases, that percentage just plummet. An elderly female might be down to only 45% water. That gives her a much, much smaller reservoir, making her way more sensitive to fluid shifts. This is exactly why a one-size-fits-all fluid order can be so dangerous. And this is a brilliant illustration of where that water is hiding. 2/3 of it, it's locked away inside our cells. Only 1/3 is floating around outside the cells in what we call the extracellular fluid. And that's sodium's kingdom. Sodium is the king of the ECF. So when we draw blood and check a serum sodium, we're really only getting a tiny snapshot of that smaller extracellular compartment. So when a patient can't eat or drink, how do we replace their normal daily water losses? Well, we use a timeless, high-yield formula, the 4-2-1 rule. It's just a simple weight-based shortcut to figure out their baseline hourly fluid needs. It's 4 milliliters per kilo for the first 10 kilos, 2 for the next 10, and then 1 for every single kilo after that. Let's put it to the test, shall we? Have a look. For your standard 70-kilo adult, what's the maintenance rate going to be? Let's just run the numbers real quick. So 4 times 10 is 40. Then 2 times 10 is 20. Okay, so we're at 60 so far. And then 1 times the leftover 50 kilos is 50. You add them up. 40 plus 20 plus 50 gives you 110 mLs per hour. Simple as that. But you got to remember, the 4-2-1 rule is just the starting line. Surgery is anything but a baseline state. If your patient has a fever, you need to bump up their fluids by about 10% for every degree Celsius over 38. Got an open abdomen? That's huge evaporative losses. You got to add more. But on the flip side, if a patient is on a ventilator with a humidified circuit, their respiratory water losses can drop to almost nothing, which is a classic setup for retaining water and, you guessed it, developing hyponatremia. Okay, so we know where the water lives, and we know how to replace it, but what actually controls it? It's time to meet the body's water bosses. Think of it like a superhero duo. ADH is the water boss, and the renin-angiotensin system, or BRAS, is the salt boss. And for hyponatremia, the water boss is definitely our main character. ADH, or antidiuretic hormone, does exactly what its name says. It's antidiuresis. It stops you from peeing out water. When your brain releases ADH, it travels down to the kidneys and basically opens up these little water channels. This pulls pure, free water right back into the body. And the result? You make less pee, the pee you do make is more concentrated, and your blood gets more watery, which, of course, lowers the sodium concentration. And this, right here, is the absolute key. What tells the body to release ADH in the first place? Normally, it's high blood concentration. But in a surgical patient, forget about normal. A whole bunch of powerful, non-osmotic triggers just completely take over. Pain, the stress of the operation, nausea, the opioids we're giving for the pain, even just being on a ventilator. All of these things are screaming at the brain to dump ADH no matter what the sodium level is. This is the central reason for postoperative hyponatremia. So let's really nail this down. Which one of these is a classic non-osmotic trigger in a post-op patient? It's got to be C, postoperative pain. This is so critical. It's why managing your patient's pain and nausea isn't just about making them comfortable. It's literally how you manage their water balance. Okay, physiology is down. We've got it. Now let's build the clinical playbook. Your pager goes off, the sodium is low. What is the very, very first thing you do? This is step one of our mantra, osmolality first. This is non-negotiable. Before you even think about doing anything else, you have to know the serum osmolality. This one lab value will instantly sort the entire problem into one of three completely different buckets. So if the osmolality is high, you've got hypertonic hyponatremia. This isn't really a sodium problem. Something else, usually glucose, is so high in the blood it's pulling water in and just diluting the sodium. If the osmolality is normal, it's probably just a lab error called pseudohyponatremia. But if the osmolality is low, that's hypotonic hyponatremia. That's the real deal, a true excess of body water. And that's where we're going to focus next. Now, for that hypertonic case, here's a super high-yield pearl you absolutely have to know. You can calculate the real sodium. The rule is simple. For every 100 the glucose is over 100, you just add 1.6 to the measured sodium. So a patient with a glucose of 600 and a sodium of 130, well, their corrected sodium is actually closer to 138. The problem isn't the sodium, it's the sugar. Okay, so we've confirmed our patient has true hypotonic hyponatremia. Now what? We move to the second part of our mantra, volume second. This means we have to get up, go to the bedside, and figure out the patient's volume status. Are they dry? Are they just right? Or are they puffy? And this table just simplifies everything perfectly. If the patient is dry, they're tachycardic, they're orthostatic, they are a hypovolemic. They need salt and water, so you give them isotonic fluids. Easy. If they are puffy, you see edema, their neck veins are bulging, you hear crackles in their lungs, they are hypovolemic. They are totally overloaded, so the treatment is diuretics and fluid restriction. And if they seem just right, well, they're euvolemic. This is the classic picture of SIADH, and the main treatment there is fluid restriction. All right, let's talk about a classic neurosurgery board exam trap and the likely reason for that page from the ICU, telling the difference between SIADH and cerebral salt wasting, or CSW. Their labs can look identical, low serum sodium, concentrated urine, but their treatments are polar opposites. SIADH is a too much water problem, so you restrict fluids. CSW is a losing too much salt and water problem, so you have to give fluids. You absolutely cannot get this wrong. So how in the world do you tell them apart? Listen, this is the whole point. You can't do it from the lab slip. It's impossible. You have to go to the bedside and physically examine your patient. The patient with CSW will be clinically dry, volume down. The SIADH patient is going to be euvolemic, maybe even a little bit wet. Your physical exam is the ultimate tiebreaker. We are in the home stretch now. Let's wrap up with how to fix this safely, which brings us to our final rule. Rate of correction always. And I want you to remember something. Hyponatremia is not just some number you round on. National data shows that even mild low sodium before an operation is a major risk factor for post-op complications. Think of it like a giant red sticky note on that patient's chart. Okay, worst case scenario, your patient is actively seizing from severe hyponatremia. This is a neurologic emergency. But your goal isn't to make the sodium normal. Your goal is to stop the seizure. The answer is a small, fast bolus of hypertonic saline, 100 mLs of 3% saline pushed over 10 minutes. That's it. This will bump the serum sodium just enough, maybe 2 to 4 points, to calm the brain down and stop the seizure. And for every single other case, you must obey the speed limit. Correcting sodium too fast causes a devastating permanent brain injury called osmotic demyelination syndrome. The rule is simple, and you can never break it. Never correct faster than 10 to 12 points in a 24-hour period. And for your really high-risk patients, alcoholics, the malnourished, those with bad liver disease, you go even slower. You're aiming for just 4 to 6. So let's go back to that 3 a.m. page. Pre-op, sodium 128. You have a plan now, don't you? You're going to check the osmolality, you're going to assess their volume, and you're going to seriously consider delaying that elective case. And for that ICU patient at 121, you know you have to get to the bedside to figure out if they're dry and need fluids or wet and need restriction. You've got the pearls now. Osmolality first, SAADH is wet, CSW is dry. 3% saline treats symptoms, not numbers. And you never, ever break the speed limit. You've just mastered the water story. You're ready.